Okay, so Dr. Jeff Mason is with us, and we're going to talk about, this is perfect. This show is made just for me. What is the most common cause of knee pain in middle-aged men? There we go. That's me.
Yeah, there we go.
What is it? It's exercising. You know, my life was good until I started exercising, and then everything started falling apart.
It was all of those years that preceded when you started exercising that got you there.
I hear you.
Yeah, so I mean, one of the things that I'm sure you see, and I know I see in my practice, is we have a lot of these middle-aged, let's call it these middle-aged men, like 50-something. And I don't know if you're in that category yet or not there, Dr. Mason. But
Easily,
okay. But, you know, I mean, these knees and these joints, particularly the knee, is getting worn out. And what are the options? I mean, if you've got a little osteoarthritis in your knee and you want to stay active, I mean, and you're too young or not ready for a partial knee or total knee, is there any options?
Well, it is a fairly difficult thing to treat because you're usually confronted with someone who is having pain in a knee, for example, but really what's gotten them there is the lifestyle they've been living since they were, 15 or 25 or something like that. So there are people who show up and they have significant arthritis, and sometimes by the time you get into your middle 50s, you can theoretically start becoming a better candidate for a total or a partial knee replacement. But we see plenty of people who have wear and tear who are not yet in that category. Sometimes these people have some arthritic change because of some remote sports injury, but other times it's just because of the life they have lived. And so there are times when they can be helped by a specific procedure like an arthroscopy if they have a torn meniscus and that kind of thing. But a lot of times you're trying to change their life, which is pretty difficult to do with anyone who's 50-some years old.
Yeah, because if you have that arthritic knee, there's been some research that shows if you can get exercising and move right, increase flexibility and strength, it might buy you some time.
It's been shown that an arthritic knee that is stronger has better function and less pain than an arthritic knee that's weaker. So there's definitely a role for the right kind of exercise and the right kind of rehabilitation, and it can be quite significant.
I think exercise, programs and working out of the gym is more prevalent these days than it was even like 10 or 20 years ago. I mean, I go to the gym in the morning and at 6 o'clock, the same people are there working out and they're all, in their 60s and 70s. It's the only place I go where they call me kids still.
Yeah.
So
there you go. That's why you go?
Yeah, exactly.
Go to the sauna,
the only
read the
reason.
paper.
But is there something like, I mean, I can't I can't run anymore with my fake knee, but the elliptical works really good. How about weights to increase strength in your knees?
All of these things can work, and one is a very individual thing, but low impact is typically better than high impact. So we're always trying to steer people onto the elliptical, onto bicycles, into the pool. Weights can be a very good thing, but it's a matter of degree. What you're trying to do is not particularly overload that part of the joint that's most irritable or is weakest.
It depends on who's walking by.
Right.
While you're doing it. You know what I mean?
You know what's interesting is, I guess if you go back maybe 15 years ago, it wasn't uncommon to take a arthritic knee and scope it and debride that arthritis off that joint and kind of clean it up. Are you still doing that debridement procedure, or has it been found that it's not really effective?
It's typically not effective. Normally when we do it, we're doing it in the context of being in the knee for some other reason that's more likely to help. But the issue with these knees is that a lot of people, when they get into their 50s, may have a meniscus tear, and so you don't want to just say, well, the MRI shows you have a tear, we're going to scope your knee, everything is going to be great. Sometimes the knees hurt because they're irritated and weak, and this thing that you've seen on the MRI is not really the cause of symptoms. So you want to evaluate them pretty carefully and try to get an idea of what their life is really like. What is it they're doing that is contributing, and what is it they're doing that is helping their knee pain?
If someone has this knee pain or this achiness that they have in their joint with activity, what kind of things should they look for? I mean, I guess what I'm asking, is there any kind of swelling or locking or buckling that needs to be looked at where it's more than just arthritic changes?
Yeah, I mean, typically if you have a lot of mechanical symptoms, that really tips off the orthopedic surgeon that something more direct or aggressive needs to be done, where you have some variety of loose body in the knee, whether it's a piece of cartilage or part of a torn meniscus that's catching and grabbing, because that can produce really painful, irritating symptoms. Knees that swell repeatedly, that gets your attention too. You may have an irritated knee where there's a bit of extra fluid into it, but when people say, gee, every week or every several weeks it swells up, it makes us sit up and think that something more than a little bit of therapy might be necessary.
You know, you talked about the life you've lived. That's not necessarily sitting, smoking, and eating. If you've been hanging drywall up and down the ladder for 25 years, that'll do it too, right?
Oh, absolutely. I mean, people often ask me what my practice is like, and I say, well, in terms of the types of procedures I do, you'd almost define it as a sports medicine practice, except in many cases, instead of doing it to a 22-year-old outfielder, I'm doing it to a 52-year-old Boeing mechanic.
Mm-hmm. Who's been crawling around and, right?
Yes, lifting this, carrying that. I mean, a lot of the industrial life is not particularly healthy to the human body.
Right.
And is it like I said, I had my knee replaced, and it's happening to younger people these days, right? With the way the medical world is working.
It is happening to younger people, and it's not entirely clear whether that's such a great thing or not. Just because we have the technology doesn't mean it automatically has to be used. But it's very difficult to look at someone who has pain, and you know what the cause of pain is, and you have something that will treat it, and then say, well, it's not a great idea, and come back and see me in 5 years. And the person, of course, says, what am I supposed to do for the next 5 years? You know, stay at home and limp?
Right.
And so there are times when the indications are stretched a little bit only for the best reasons.
Is there anything on technology-wise, kind of on the forefront of resurfacing or growing cartilage in a lab and then transplant it back into the knee where that cartilage defect is?
There are technologies to do that. They work better where you have what we call a circumscribed lesion, which is to say a divot rather than generalized wear and tear. But regrowing cartilage is proven to be very difficult to do. And basically the reasons are, in the simplest form, is one, the articular cartilage almost is not living tissue. So its capabilities for healing, regeneration, and this sort of thing are very limited. Second of all, if you have some technique, you know, in a biochemistry lab, as it were, or a genetic lab to turn the cartilage on, well, you know, uncontrolled and growth, that's what we call cancer. And so you're dealing with a situation where saying, how do you turn the cell on and then turn it off? And so there are lots of incredibly difficult to understand techniques that are being worked on, but they're still a ways away because you really have to understand how to make a cell behave before you can start reliably thinking of ways to cover bone with new cartilage, except in certain comparatively isolated ways.
Right. Any synthetic material that's out there that looks promising?
The synthetics have not yet been promising. Every few years another one comes down the pike, and usually they disappear pretty quickly.
When is the choice? I mean, like Maury has a total knee. When is the choice to do a partial knee?
Normally for a partial knee, what you want is to see that part of the knee, whether it's medial, which is most common, the inside of your knee, or lateral, or underneath the kneecap, to have severe wear that's quite isolated. So you do see that on a regular basis with the inside of the knee, less commonly with the other parts of the knee. So a lot of patients who have partial knee replacements have had an arthroscopy in the not very distant past where the surgeon can look at that part of the knee and say, okay, there is significant wear here, and gee, the rest of the knee really looks good.
Is the problem you were saying you don't know if total knee is the way to go these days? Is it because of the way they last? I mean, do they last? So is it like 25 years or something like that?
Well, the problem is if you have your total knee put in and you're elderly and you're not particularly active and you're doing it for pain control, I think if you have a total knee put in and you're 78, if you live to be 100, it's probably still going to be good for you. If you have a total knee put in when you're 50 and you immediately, because you're feeling good, start resuming a 50-year-old active lifestyle, it's not going to last 20 years or even 15 years. It may last much less than that. And that's why it can be a problem when you can't just keep putting in new knees. Again, it's not like the water pump in your truck. You have so many chances.
Wait, I don't put in new water. I just keep driving until the sound goes away, basically. So, yeah. But I completely understand. I mean, since I got the new knee, there's some things I can do. There's some things that it kind of like, hey, buddy, what do you think you're doing here? So,
but it's a great option for you. I mean, to have that pain and to live with that lifestyle where you're in pain constantly and your activity level diminishes. and you get frustrated, to have your knee replaced, whether it's partial or total, is a great option, because most of these people, after the replacement 4 to 6 weeks later, I mean, they return to fairly normal function.
Yeah, a lot of them do eventually. I mean, it's a tough operation. It takes time to get over it. But overwhelmingly, when people have gone through it, they say, gee, I should have done this a few years ago.
Right. They wake up and, like you said, they've got the operation to kind of deal with, but that achiness, that joint pain is fairly eliminated.
Yeah, it's not uncommon that people report after a successful arthroplasty that their pain is completely gone.
Yep.
Not better, but gone. So it can be a wonderful operation.
So how many patients do you see that come in and say, when you say how long does it hurt, what year is it? Do they?
Oh, yeah, it's not uncommon because, a lot of people are plenty tough, and they'll say, gee, this knee's been bothering me for many years. I'm just finally reaching the point where I can no longer tolerate it.
And that's what it probably comes down to. It comes down to a quality of life. I mean, I just can't live with this pain anymore.
Yeah, there are very few people who come in and they say, gee, my knee's been hurting for a month. I think I need a knee replacement. Usually they don't, but that's very rare. No, more often, people have a pretty good idea of when they need something that big.
I think they ask for the drugs first.
Yeah.
And then the knee replacement.
Yeah, right. Tell us
afterwards.
about, I'm curious to know, because I don't see it a lot anymore, and maybe you do. We just don't get to the bracing aspect, preoperatively. That unweighting brace, that 3-point brace.
Yeah, the unloader braces, we use those under certain circumstances. In many cases, they're not well tolerated because, they're stiff and they're not that heavy, but they're heavy enough, and they put pressure on the knee and they sort of drag your knee over a bit and try to change the weight bearing across the damaged joint. So they can work well, but some people say, gee, it works pretty well, but I find at the end of the day I'm so tired of having the brace on that I only wear it this often. We have a significant number of failures with braces.
Is that before surgery or after surgery?
Before surgery.
Before surgery. So you put a brace on to try to get through it?
Well, yeah, the brace
until surgery happens?
Yeah, technically the brace is an option to unload the irritated part of the joint. Essentially, you unload it, take the stress off of it, and sometimes people can function and get by and basically buy some time. Ultimately, they're probably going to end up...
If you want to be more involved, we do the same thing where we actually do what's called an osteotomy, where you cut the bone right below the knee and you change the angle of the bone and thereby shift the weight bearing in the knee from the worst part of the knee to the better part of the knee. And that can, good osteotomy can last a decade. And so sometimes if someone's quite young and they come in and they say, well, my knee is pretty wrecked, I'm 39 years old, and you say, well, let's try an osteotomy to reduce your symptoms until you're a better candidate for a more definitive procedure.
Yeah, do you still see a lot of those and do them on occasion?
Yeah.
Okay, all right.
All right, Dr. Jeff Mason, Ever Bone and Joint. If you have knee pain and you're listening to this, I had knee pain and I was listening to this, and I went to Ever Bone and Joint and got it taken care of. You can too. everboneandjoint.com is you want to go check that out and go see Dr. Jeff Mason. Thanks for coming on.